Welcome, everyone, to tonight's activity called Faculty Feud. Please bring your attention to the screen where you can see that this is going to be an interactive experience during this event. Join on your personal device using the QR code. You'll not only be able to view the slides and look at today's content, you can ask questions, but most importantly, you're going to be participating in polling activities. We're going to be talking tonight about discovering the winning strategy for seizure rescue and seizure action plans. But it will not only be presentations, but it'll be interactive polling. We have a large number of people online tonight, and we have everyone who is here live in the audience. And you're going to play a very important role because we have two teams. We have the Rescue Rangers over here, led by Dr. Long. We have the Action Architects, led by Dr. Clark. It's a competition, and you're playing a key role. By the way, everyone who is live tonight, right here in the room, is part of the Rescue Rangers, so you're competing for Dr. Long is your captain. And all of you, those of you who are online, you're going to be in the polling session, creating points and scores, and Dr. Clark is your captain. So we'll see how everyone does as we move on. All right. So may I borrow yours for a second? Thank you very much. I'm Dr. Tracy Glauser. I'm professor of pediatric neurology at Cincinnati Children's Hospital, and I'm delighted to have you join me tonight. And along with me in this presentation, this symposium, is Dr. Dave Clark to my right. He is professor of neurology and pediatrics and chief of pediatric epilepsy at Dell Medical School. And to my left is Dr. Lucretia Long, clinical associate professor of neurology at The Ohio State University. So let's first talk about seizure emergencies, because everything we're going to deal with today about seizure medications and seizure action plans are because we have seizure emergencies. And I want you to think about seizure emergencies in two big categories. We first have one category which is called seizure clusters, although some people call it acute repetitive seizures. We're going to do a deep dive on all the different names of that today. And that's because there's no clear, standardized, or consensus definition for what those are, but they're often described best by their frequency, their time between seizures, the patient's baseline pattern, and these factors vary across patients. So it really is important to listen to your patients. And we'll talk more about seizure clusters and acute repetitive seizures in a minute. The second main category of seizure emergencies are prolonged seizures and status epilepticus. These are the well-recognized convulsive or clinical or electrographic seizures that last 5 minutes or longer, or can occur where there's repetitive or recurrent seizure activity without full recovery between the seizures. So let's go back for a second to that first type of seizure cluster, because we're setting the stage to discuss that tonight, and we need to say that there are many different terms by which people call seizure clusters, and you can see them on the left side of the slide. However, when we design therapies and rescue medicines for them, the FDA doesn't want 5, 10 different terms or definitions. They use one specific definition, so I'll show that to you on the right-hand side of the slide, because it's a good jumping off point, and we'll discuss more in a few minutes. But the jumping off point is, think of seizure clusters as intermittent, stereotypical episodes of frequent seizure activity that are distinct from a patient's usual seizure pattern. There are consequences of these types of clusters, a wide variety of consequences, including the evolution to status epilepticus that you see in the bottom left-hand corner of this circle. In addition, not only if they go into status epilepticus, but just by having clusters, people end up in the emergency department and use lots of healthcare services. Clusters are associated with increased mortality and an increased risk of SUDEP. They have a higher financial burden, not only on society and on hospitals, but more importantly on the patients themselves, who end up having to utilize a lot of health care. They can lead to neuronal injuries. They can make people at times treatment resistant. You can have post-ictal psychosis. You can have physical injuries. So seizure clusters are one form of seizure emergencies. I did say that this was going to be interactive. So here's where you come in both in person and online. We're going to ask you now a simple question, and you should have it on your phones also. What is your favorite thing about Atlanta? And we're going to use this question to show you how the polling is going to go on. So pick one of the following. There isn't one right answer, and you'll see that concept occur over and over. The food, the history, the people, the tourist attractions. What do you think is your favorite thing about Atlanta? Please vote, both in person and online. Remember, the in-person people are part of the Rescue Rangers team, and the online people are part of the architects, the action architects. So this is an aggregate of everybody. Everybody, both online and in person. You see that it was pretty evenly split, that there's not one particular thing about Atlanta that is the favorite. However, we brought a third group in too, because before we had the symposium, we actually went back and asked groups of people online what they thought. So you can see here, this is what the general survey before the symposium was, and you can see that the people like the food a little bit better than everything else. So you'll see this over again. You'll see what aggregate, online, and in-person do, and then you'll see what the pre-symposium survey showed. And then we're going to ask 2 questions after each round. At the end of the second question, we'll show you the aggregate scores of the teams against each other. All right. So let's dive into the first set of questions. For which type of pediatric patient are you most likely to prescribe a seizure rescue medicine? Anyone with epilepsy? Patients with a DEE? Patients with occasional prolonged seizures? Patients with evidence of history of seizure clusters? Patients with evidence of acute repetitive seizures? Patients with rare generalized seizures, or patients who have a parental anxiety and preference? Please vote now, both in person and online. We're going to first show you the aggregate of all the people attending the symposium. Anyone with epilepsy, 35%. And then the next in line is patients with evidence of acute repetitive seizures. And third, patients with evidence of seizure clusters. And last, not last, but the fourth one, patients with a DEE. All right, now let's show you what the general population who voted before the symposium. Anyone with an epilepsy diagnosis was the top, and only in patients with occasional prolonged seizures. All right, so you get to see how you compare to the general peer population. So let's do our second question in round 1. What's your definition of a seizure cluster? What is your definition? 2 or more seizures within 24 hours with recovery between events. Multiple seizures over a short period that deviate from baseline. 3 or more seizures in a day requiring rescue medication. Recurrent seizures occurring before full recovery to baseline. Or acute increase in seizure frequency over hours to days. Please vote. The first one will be the aggregate across people attending in person and online, and then you'll get to see what the rest of the general community voted before the symposium. So the top definition in our group attending tonight: multiple seizures over a short period that deviate from baseline pattern. You might have been listening to what I said from the FDA. Great. And then 2 or more seizures within 24 hours with recovery between events. Excellent. So let's see what the general population of our peers said. Multiple seizures over a short period that deviate from baseline patterns. So we're starting to see some consensus between what people thought before the meeting and what we've been talking about at this particular meeting. But now here we go with the faculty feud. We're going to tabulate the scores, and right now, Rescue Rangers, to my left, Dr. Long's team, has taken a lead over the Action Architects.
Online, come on now.
This does not make Dr. Clark very happy. But Dr. Clark is now going to get up and talk about what you just answered about. When do you consider seizure rescue medicines in pediatric patients? So I'll turn it over to Dr. Clark.
Thank you. We're still the cool kids online, guys, so come on now. So let's talk about pediatrics. When do you consider seizure rescue medications in your rescue plan? And I'll give you two case scenarios. The initial one is a 9-year-old right-handed individual, started having events at 5 years of age. Even before that, had some attentional problems, some dyslexia, which we see often preceding the seizure. Has experienced events at school, often being teased, hence the stigma. And the seizure, he feels it coming but can't better describe it. Stops, unable to speak but can hear. Body stiffness, cycling with both legs a little bit more on the left. Vocalization, a scream but unformed words, and this fearful look. Very brief. But they have these clusters 3 to 5 times a week. But the clusters, if they persist or increase or occur more than 3 times, then he goes into more and more clusters. It just does not stop. So let's contrast this with a 16-year-old female who's left-handed like myself, normal development, onset at 12 years, but first generalized tonic-clonic seizure at 14, and that's when they started management. Never had any at school, intelligent but very anxious and socially withdrawn. And initially for this individual, she used to just have jerks. But those jerks, as they crescendo or get longer, she often goes into a generalized seizure. So what are the questions we tend to ask for these individuals? Are these two patients having seizures? Is case 1 a paroxysmal movement disorder? It does occur during sleep. Does case 2 have both seizures and non-epileptic events, or some people call it functional seizures? Why no seizures at school? And if these are seizures, when do you treat? In case 1, is it immediately? Is it 1, 2, 3 clusters? For case 2, how long do you wait before intervention? You know if the jerks crescendo, she'll go into a bigger one. When do you initiate treatment? And then the kicker is, with both individualized patient populations, which rescue medication do you use? Shorter acting, longer acting, what else do you take into account? So we sort of know that these two patients actually have epilepsy because of what we have heard, because of the video, and we can confirm it with EEG. But just about every seizure type has a non-epileptic mimicker, so you have to be very careful. And with the constantly changing updates and classifications, we know that our initial patient, for the most part, could hear, was fully alert, so focal with preserved consciousness. But every once in a while would evolve, altered consciousness, and spread along that circuit, becoming generalized. And for our second patient, the initial jerks, if they go on for long, then it evolves. So already you're getting the picture. Is it cluster? Is it prolonged seizure? What are we dealing with? And if we know that, what medications do we have in this country, federally approved, and or other medicines? So we have diazepam in 3 forms. It could be rectal, could be intranasal, could be buccal. And then we have midazolam. But off-label, we have sublingual lorazepam, which is also used in Canada quite a bit, and then they have buccal midazolam. But again, what do we choose? For the first 5 minutes that they're seizing, do we really wait 5 minutes? Is it related to seizure type? Could we wait a bit longer? Motor, non-motor? Prolonged seizure, how do we better characterize that? Or should we be using the term? And when do you initiate and/or call something a cluster, as alluded to before? You start that initial therapy, again, there are concerns about what to use, and as you escalate therapies, then you get access, but you start including what gender, what's the underlying condition, etc., etc. I love this chronobiological seizure spectrum that was suggested by Sir Ragino. They're isolated seizures, then there are these unprovoked repetitive seizures, but they return to baseline longer in between. But then at some point, that acute repetitive seizure that escalates. But you also have prolonged seizures, which in this case, they're distinct from status. But if you stick to that definition of 5 minutes, perhaps you would have stopped, but you would have intervened. Or do you start a bit earlier? So what does the NIH say? A characteristic episode of multiple seizures within 24 hours should be likely characterized as acute repetitive seizures. But for kids, how about 12 hours? And how definitive is this? Suppose I have someone with DEE or spasms or multiple drop attacks. Do I always intervene at that time? Hence the compounding and confounding issues about what a cluster is. Is it greater than 3 seizures? Who determined that? Is it what was previously called complex partial, then focally impaired and aware, or focally with altered consciousness? What is it? What is this feature? We know that convulsive seizures last very seldom longer than 2 minutes, and I'll show you some literature about that. But again, we're left with how individualized should we tailor that management towards the patient population? Do we sometimes have to treat as soon as possible? Do we wait for 3 to 5 minutes? When do we administer? What do we administer? And when do we call it a seizure cluster? We can draw from ILAE and from definitions, but how many times are you going to sit down with a family member and say, this is a condition resulting either from the failure of the mechanisms responsible for seizure termination or from the initiation of the mechanisms on and on. And then they ask you, why 5 minutes? And you say, well, T1 said. So this is likely not the case, right? With my patient population, some of these parents are going to come back and say, this makes no sense to me. Is it semiology, etiology? Does the EEG help? And what about age? So how did they come up with 5 minutes? Some of it is subjective and objective, because if you look at the literature, this study showed that a tonic seizure lasts about 18 seconds, the longest being what we used to call secondary generalized tonic-clonic, or secondary to bilateral synchrony, lasts about 2 minutes. So we're 5 minutes. So in pediatrics, we have a little bit more leeway to push, because in this study, on average, they were about 3.6 minutes, 2/3. And then we know that 7 minutes, it's longer. So why not give earlier? But I still come back to the question, is it 5 minutes? Then the question is, who should be aware of the seizures and rescue medications? So I think the initial circle is quite easy. Parents, school nurses, other PCPs, teachers likely, but quite often they draw in from the outward circle. So grandparents may need to know, and caregivers, best friends, and you have to make providers, families, and the patient, if they're quite conscious and with it, know that they're outside advocates that are advocating for them. And where do you go for that advocacy? These are some of the practical questions that some of you may be asking, but there are a lot more. Are drugs used as anti-seizure medicines appropriate for acute seizure therapy? I have families that come in and ask that question. My doctor said to give Keppra, but my patient still seized, or levetiracetam. What's the safety? Well, they're very, very safe. All medications I spoke about have shown good efficacy and safety. Now, can I say never? Quite often I have to explain this to families. Can you transition from rectal to intranasal? How about entertaining not an epileptic patient, but an individual with epilepsy? What's the stigma of a teenager having a seizure at school and you're pulling down garments to give rectally? So of course you can transition. And then our acute seizure therapy is easy to administer. We administered Diastat for ages, rectal diazepam for quite a while, but it can be difficult sometimes. Suppose someone is a bit heavy, suppose they have cerebral palsy, suppose they have an infection or diarrhea. How is the effectiveness of seizure medicines chosen? In my mind, it's very simple. The acute rescue medicines work if they stop the seizure. And what should be considered with that transition? You have to start it early. You have to engage with that provider, although the action folks, I don't know, but you have to engage with them. Begin a genetic transition program. Therapies are important. Notify that adult provider what you're using for rescue. Look for continuity. And then there are many topics that need to be covered. I'll only go through a few. If someone is transitioning to a university level, you've got to keep reminding them sleep is important, reduce alcohol use is very important. You have to look at birth control, importance of compliance, etc., etc.
So what you've seen so far is we've talked about different types of seizure emergencies, clusters or acute repetitive seizures, and status. And Dr. Clark has taken us through what you would expect from the very beginning in pediatrics. But before we go into adult discussion, let's talk about two more questions. And so if everyone could pick up their phone or log on. So approximately what proportion of your adult epilepsy patients have that type of seizure action plan that Dr. Clark was alluding to, where we identify when someone should intervene and how they should intervene? If you don't see adult patients, pick the top one, or pick the percentage below it. So we again are now starting the transition from looking at kids to looking at adults. About 30% of the overall audience tonight don't see adult patients. But it's pretty evenly split across 0, 25, 50, and 75 and 100% of adult patients are getting seizure action plans. So let's see what the population who took the question before the symposium said, and we'll compare ourselves to our peers in the general neurology and population. In that case, 25% was the leading answer. About 30% of them didn't see adult patients, but very few actually had 100% or 75% of their adult patients have seizure action plans. So Dr. Clark established seizure action plans, and dealing with seizure emergencies are very common and important to do. Dr. Long will tackle that, but first, we have one more question. So which of the following represents your biggest barriers to prescribing a seizure rescue medicine in your adult patients? Are they only indicated for pediatric patients? Is it because only kids have seizure clusters? Is there no clinical data that it actually works in adults? Are you not aware of any options for seizure rescue in adult patients? Do adult patients refuse to use rectal diazepam, or you don't have any barriers? Please vote, and we'll see what the aggregate of the people who are attending tonight say. And then we'll compare it to the pre-symposium voting. But we're already starting to see a difference between the adult and the pediatric populations. So the most common answer in our pre-symposium survey was, I don't have any barriers, followed by, I'm not aware of the options for seizure rescue medicines in adult patients. So now we've established that there's a difference in practice between adults and kids. At the same time, Dr. Clark has identified that seizure clusters occur across age ranges, and status epilepticus, as we all know, goes across age ranges. So let's see how the two teams are doing right now. Okay, I think that was the answer. Not aware of the options for seizure rescue in adult patients. I don't have any barriers. And there's no clinical data where the top scores. All right. And there's still Rescue Rangers are winning. Dr. Long is ahead. With the Action Architects, you can just imagine how competitive these two are. And they've been going at it pre-symposium a lot as to whose team was going to be better. But getting back to the topic, overcoming barriers in adult onset epilepsy, about what's stopping us from using seizure rescue therapies in adults. And I'll turn it over to Dr. Long.
Thank you. You guys are doing an amazing job. I'm going to pay all of you afterwards. So keep up the good work. But we're going to kind of switch the gear here tonight and talk again, as Tracy mentioned, about how we might overcome barriers in terms of implementing action plans and rescue therapies in our adult patient population. A barrier of being able to advance the still not moving.
There you go. This one works. Green button.
Okay. I'm going to start off by giving you an overview of a study that was done in a Germany cohort. And so they looked at over 481 adults with epilepsy, and these were patients who had a history of seizure clusters. And only 27% of those patients actually reported receiving a prescription for emergency seizure medications. Now, this was published in 2018, but the data were actually gathered in 2015. And so there was a limitation in terms of the rescue therapies that were commercially available there. But you can see from the slide that the most frequently used rescue medication was oral lorazepam, followed by the buccal midazolam, and then rectal diazepam. And then, obviously they reported some difficulty with medication administration, and we'll talk about that a little later, again, as we talk about the barriers, particularly in the adult population in terms of rescue therapies. Interestingly, also in this cohort, the most common indication for administering emergency medicine, many of them were actually getting medications before or after every seizure, which can potentially be problematic in terms of overuse. But also seizures continuing for several minutes was another indicator. Now, when you look at the predictors for adult patients who are more likely to receive rescue therapies, we see that patients who have a care partner who resides with them, those with convulsive seizures, status epilepticus, structural etiologies, those patients with polytherapy, higher seizure frequency, and lower age of epilepsy onset and younger age are all predictors that will indicate that these patients and these characteristics may potentially be more likely to receive rescue medicines. Some of the barriers, and we talked a little bit about this earlier, number one is the route of administration. And many of you in the audience remember years ago where the only thing we had in terms of rescue therapy was a rectal diazepam. And so when you think about the stigma associated with that, the social challenges with administering a rectal medication, not surprising that the route of administration can be a huge barrier. Lack of access is another challenge. I typically tell my students or newer colleagues that I'm mentoring that it doesn't matter how effective or well tolerated a rescue medication is if the patient can't access it. So clearly, challenges with insurance coverage and costs can be huge barriers as we look at implementation and increasing utilization for rescue therapies in adults as well as children, actually. And then we talked a little bit earlier, Dr. Clark did an amazing job talking about the consensus of a definition of clusters. And what I really want you to begin to think about, it's important to define what a cluster is, but more importantly, it's really imperative that you appreciate the importance of determining which cluster is necessary for treatment intervention in your patient. So the definition is important, but being able to really customize and understand your patient's pattern is super important as you look at customizing intervention for seizure clusters, again, for your particular patient. A lack of understanding about the role and importance of rescue medicines. I think there was, early on some challenges in terms of percent of the audience not understanding that rescue therapies had been used in the adult patient population, and they worked just as effective as they do in our pediatric groups. Fear, anxiety, we're going to talk a little bit about some misconceptions related to rescue therapy. So the first one is actually acute seizure therapy is necessary for children with epilepsy, but not for adults with epilepsy. This is clearly a misconception. We know that acute rescue therapy is appropriate for adults. Adults, as Tracy mentioned earlier, adults have issues in terms of those challenges with prolonged seizures, cluster seizures, and the risk of status epilepticus. And as mentioned, patients with cluster seizures are also more likely to die of SUDEP. There's a direct correlation between cluster seizures and the increased risk of status epilepticus as well as SUDEP. We see this in our adult cohorts as well. Seizure action plans or acute seizure action plans are only for school-aged children, and certainly those of you in the pediatric space are doing a much better job than we are in the adult space, but this is one of the reasons that we have symposiums like this is because we're trying to move forward and implement these seizure action plans in the adult space as well. Clearly, in my mind, all patients with epilepsy should at least have an opportunity to discuss seizure action plans, whether you are a pediatric patient or an adult patient, and we'll walk you through some clinical opportunities to disseminate seizure action plans in your adult clinics as well. We'll talk about that a little later. But all patients with epilepsy should have the opportunity to at least discuss a seizure action plan. Myth number 3, oral benzodiazepines have shortcomings for adults. Again, some of the off-label uses of medications can potentially lead to some of these shortcomings, but if you're utilizing these rescue therapies appropriately, they are safe and effective for adults as well. And then finally, in patients with clusters, you must always wait 5 minutes. This is something we are trying to change the paradigm. If you remember, a 5-minute duration of a tonic-clonic seizure constitutes the definition for status. So why are we waiting until patients are in status before we're intervening? I want you to kind of think about that as we move forward with today's discussion. So again, this is a misconception. You want to begin treatment as soon as possible based again on your patient's clinical presentation. I'm highlighting the importance of clinical presentation, and then considering the FDA-approved seizure rescue medications when possible. So when we're talking about improving the use of rescue medications in adults, you again want to customize that, evaluate whether or not the patient is suitable for a rescue therapy, look at the patient's history. The pattern is really, really crucial as you're looking at customizing care for your patient and their family member dealing with these acute repetitive seizures and seizure emergencies. Communicating with colleagues across settings. At Ohio State, we have an electronic seizure action plan, and so it's wonderful to have an opportunity where that seizure action plan can be communicated across different disciplines. So the ER, primary care, and obviously general neurology and in the epilepsy clinic. So being able to communicate that action plan is crucial. And then obviously educating patients and their family members. I think it's really important that we allow patients to be stakeholders and collaborate on that seizure action plan. It really allows them to improve their buy-in, if you will, on managing these seizure emergencies. Some of the benefits, you guys all know this, reducing negative outcomes associated with delays. We know that rescue therapy, particularly when they are used in a timely fashion, are amazing in terms of being effective in terms of reducing the seizure burden, increasing the interval between treated seizure clusters over time. There's some data that supports that. And then we are hopeful that these rescue therapies can minimize morbidity and mortality in patients with seizure clusters. I'm going to walk you through a couple of cases here. The first is a female patient with focal epilepsy secondary to cortical dysplasia. She has a history of focal aware seizures, clusters that can progress to focal seizures with impaired awareness 1 to 2 times a month. And she, very common triggers are sleep deprivation and the menstrual cycle. All of you are aware about a catamenial impact on seizures. Depending on what studies you look at, 50 to 70% or so of women with epilepsy may have either a true catamenial pattern or catamenial influence. So when endogenous estrogen levels are high, we see a tendency for increased seizures. When endogenous progesterone is high, we see a tendency to lower seizures. But she has a catamenial pattern. You can see the baseline anti-seizure medicine, lamotrigine 400 milligrams. She has an action plan with intranasal rescue medicine. She experienced 2 focal aware seizures. And she was able to self-administer intranasal therapy. This, I thought, was a really relevant case because oftentimes we wait, or when we're talking to patients about rescue therapies, we wait until they're in a seizure with impaired awareness. Our goal is to minimize the seizure burden, so allowing that patient customizing your action plan. So when there's a seizure cluster of focal seizures without impaired awareness, you're allowing that patient to self-administer rescue therapies to minimize, again, the progression of the seizure burden. No sedation or respiratory compromise. She resumed baseline and follow-up within an hour, and then followed up with neurology to try to adjust some of the maintenance medications to minimize some of those clusters. The next case is a 42-year-old male, focal epilepsy secondary to traumatic brain injury. I love this case because it emphasized the importance of not assuming that your patients, the only patient that deserves a seizure action plan is one with uncontrolled seizures. This is a patient, seizures have been controlled for 9 months. Known triggers, very common, sleep deprivation and alcohol overuse. You can see the baseline therapy with levetiracetam 3,000 milligrams. He had a rescue therapy, seizure action plan of intranasal diazepam. This gentleman was attending an international conference, and he experienced some jet lag and some sleep deprivation that you see here. Also was out consuming alcohol at a networking event. And on the 3rd day, experienced a focal seizure with impaired awareness in the hotel room, followed by a second one 20 minutes later. Luckily, his wife was with him, trained in terms of how to utilize that rescue therapy, administered the rescue therapy, and there were no recurrent seizures that night. Follow-up, recounseled on minimizing alcohol overuse and then maintaining proper sleep hygiene. But I really like this case because how many of us have patients who have been seizure-free sometimes for years, and they experience a breakthrough seizure. I had a patient who had been seizure-free. I think she was seizure-free for maybe 7 or 8 years, and I talked to all of my patients about rescue therapies because for me, my job is to give them information so they can make an informed decision, not to dictate if it's okay for me to discuss this rescue therapy with a patient. So talked to her about that, and she had been seizure-free for a long time, and she decided it wasn't necessary. The very next week, she was rear-ended and hit her head on the dashboard and had 3 convulsive seizures. So she called me almost immediately, and we had a rescue plan in place for her. So don't assume that your patient who is seizure-free doesn't deserve a seizure action plan.
Thank you, Dr. Long. Let's start with 2 more questions. What is your biggest motivator for prescribing rescue medicine versus using maintenance therapy alone? Is your goal to reduce ER visits and hospitalization? Is it to manage the breakthrough clusters? Is it to empower your patient through self-management? Is it addressing the unpredictable seizure patterns? Or is your biggest motivator for prescribing avoiding dose escalation of a maintenance anti-seizure medication? Please vote.
Let's see what happens this time.
Forget I'm paying you guys after the session, so let's go.
Biggest motivator among all the people who are both in the room and online is empowering patient self-management, followed by reducing ER visits or hospitalizations. All right, now we'll have the opportunity to compare it to what our peers said who took this quiz or this beforehand. They also pointed towards reducing ER visits, but they raised up managing breakthrough clusters, and close third was empowering patient self-management. So you're starting to see some common themes of the people who were in person, people who were online, and the people who took the questionnaire beforehand. We'll move to the second question in round 3. What most influences your decision to switch rescue medicines? Is it ineffective seizure control, poor tolerability or side effects, the difficult for a caretaker to use? Is it patient preference or their feedback, or does it happen to be insurance or access issues? Please take the opportunity to vote your thoughts on this important issue. All right, number one, ineffective seizure control pushes us to switch rescue medicines, and that's followed by patient preference or feedback. And in third place is a tie, difficulty for caregiver to use or insurance or access issues. All right, now we'll have the opportunity to compare it to the people who took the survey before the symposium and see how they did. Ineffective seizure control seems to be very consistent. Poor tolerability and side effects, and then tied for third, patient preference or feedback and insurance or access issues. So we seem to be getting some consistent responses here. However, we'll see now whether Dr. Long's Rescue Rangers or Dr. Clark's Action Architects are in the lead in terms of Rescue Rangers are still ahead. Dr.
You should say that with a smile.
Dr. Clark's not going to be happy. All right, before we dive into the next, let's just think what we've covered so far in the first two presentations. We've talked about seizure emergencies. We've talked about a winning strategy starts with understanding that clusters can be a seizure emergency, prolonged seizures and status can be a seizure emergency. We talked about in pediatrics the importance of tailoring your approach to seizure clusters and status and prolonged seizures based upon the patient, because there's a lot of variability, and to develop a plan with them. And we talked about in adults that there's opportunity to do the same thing, and we have room for improvement, because all patients with epilepsy should have the opportunity to have that discussion. But now, if we're putting together a winning strategy and we've decided who we're going to talk to and why we're going to talk to them, how do you address the key factors in using seizure rescue medicine? And Dr. Long's going to pop back up here to talk about those factors.
Thank you. Okay, so you guys are all aware of the routes of administration for rescue medications. You can see them listed here. They're available with IV, intranasal, intramuscular, buccal, and rectal, and oral. And, there's potentially a place for all of these medications. Again, being able to, or formulations, being able to appreciate your patient's clinical presentation and determining which route of administration is relevant for that patient. You can see the list of different names based on the route of administration. Really important, though, when you're thinking about customizing an acute seizure action plan, that you appreciate the time of seizure cessation. And that's not always correlated with the peak, a medication peak, but understanding that there are data supporting the time to seizure cessation, which is basically what we're most interested in. And you can see kind of the variation listed there. There's also some advantages and disadvantages. We talked a lot about the rectal diazepam and how complicated that a route of administration is, particularly in the adult cohort, although I would imagine that most of the pediatric patients would prefer nasal over rectal. But again, you want to consider that patient's age and clinical presentation in terms of deciding which route. Just some challenges with absorption with the rectal. I think Dr. Clark mentioned diarrhea and some challenges with, again, administration. So you really want to think about the potential advantages versus disadvantages and really evaluate which one of these therapies are optimal. Looking at intranasal, again, very easy to use. You guys are aware that there are commercially available nasally administered rescue medicines that are already pre-dosed, which is wonderful when you compare the time potential that it would take to actually use that atomizer. It's wonderful to have these medications that are already pre-dosed. Provides an opportunity for ease of administration. Remember earlier on in the discussion, we talked about that study in Germany where the biggest complication was difficulty with administering those medications. So really appreciating opportunities to simplify the treatment plan for your patient and care partner suffering from the seizure emergencies. The oral route obviously does not avoid first pass metabolism. The buccal route does. And so I do have some patients, for example, that catamenial patient that I talked to you about earlier, if they have focal aware seizures. Some of my women with epilepsy can take a dose of PO Ativan around the time of their menstrual cycle, and so there can potentially be an opportunity for the oral medications, but obviously keep in mind you don't want to use those oral medications if someone is convulsing. So again, appreciating the clinical presentation, the seizure type, and making sure that you are looking at the appropriate rescue medication. So use of seizure rescue medications. Seizure rescue therapies are medications or treatments used as needed to stop the seizures as quickly as possible and to minimize the progression of seizures. Obviously, these medications do not take the place of daily seizure medications, and we kind of talked about that a little earlier during the discussion as well. Maintenance anti-seizure medicines, you guys know, are oral formulations. Inability to swallow, risk of choking and biting during emergency seizures can be a complication in terms of using those maintenance medicines. And then, you know, obviously the first pass metabolism. You want to get a medication in the system sooner rather than later. So clearly the benzodiazepines are a priority superior to maintenance medications. Those should not be used for rescue therapy. We talked earlier about the importance of collaboration and looking at factors and selecting the medicine. We talked a lot about the patient's clinical presentation, those folks with a history of frequent ER visits, and then looking again at the patient's preference, allowing that patient to be a stakeholder in deciding. Your job is to give them information so they can make an informed decision. Again, that patient engagement is really important. The environment, are they at home? Are they in the college setting, as we talked about earlier? And then the route of administration is important. I do have a patient who is the patient is a patient with LGS, and she likes to use the Diastat in the home, and then she'll use nasal diazepam in the out, you know, when the patient is out. That's kind of her preference. And so, you know, customizing that, allowing your patient to participate and educating them appropriately, I think is really helpful. Treatment success, we've already talked about this. We want to minimize the seizure burden. So acute cluster treatment, prevent the next or further seizure, and obviously rapid intervention so you can minimize the progression to prolonged seizure status epilepticus, which of course has a increase in morbidity and mortality. Success, we know what success is. We want to stop the seizure. So prevention of status, prevention of the progression of cluster seizures, minimizing the healthcare utilization. We know that patients, there's been some studies looking at patients who received rescue medicines and those who did not, and there's a clear kind of impression that patients who don't receive rescue medicines have a higher incidence of injury, higher incidence of increased healthcare utilization. Caregiver burden is huge, you know, as we look at these cluster seizures and prolonged seizures, so not forgetting the impact that this has on family members and care partners, really, really important. And then the potential to reduce neuronal damage, again, really, really important. This is just a nice summary. You guys know all of this, but a summary of the currently commercially available medications and the time the recommended time when to administer a second dose. This is, as you think about barriers, you know, there's been some data looking at some of the challenges that patients with epilepsy have in terms of determining really when to use the first dose, but also how soon can I use the second dose? We all get that question pretty frequently, so this is a nice summary. I will say there's some anecdotal data on some of the rescue therapies where they're using that nasal diazepam sooner, but the current recommendations are listed here, 4 hours, and then midazolam, 10 minutes. And so I typically tell my patients to call emergency services really anytime they become concerned. Balance on err on the side of caution. Now, obviously, when you're able to implement that seizure action plan and that family member So your new onset patient, their comfort level is going to be a little different, obviously, than your patient with a 10-year pattern of seizures with intractable epilepsy. But being able to create a seizure action plan, which we'll talk about in a little more detail later, really gives you the opportunity to customize when it's appropriate for patients and care partners to use emergency services. Obviously, if there's any kind of injury, breathing issues, if the caregiver feels as if they've maybe provided too much medication and there's some increased sedation, if there's a change in the pattern, are all potential circumstances that would warrant emergency services. But really, when you look at the goal of rescue therapy and seizure action plans, we want to minimize overutilization of healthcare services when possible. So minimize those ER visits, minimize the need for patients to be hospitalized, but then balance that out, in terms of safety as well. When to change seizure rescue medicines. Obviously, we talked about this a little earlier. If the medicine isn't effective, I'll caution you here because oftentimes what I see sometimes in clinical practice is a patient will come in and they'll say, well, I used my, nasal diazepam and it didn't work. And so I'll say, well, okay, let's talk about when you administered it, because again, the sooner you administer it, the better. So making sure they're adhering to that action plan is important. But also, as providers, I think we assume sometimes that patients understand things that we haven't educated them about. So, for example, if you have a patient using a nasal diazepam and they're at 15 or 20 milligrams, you have to educate that patient that it's one dose in one nostril and one in the other. I've had patients who are prescribed 15 milligrams of the nasal diazepam, and they'll say, well, yeah, we used that that one vial in the nose, and it didn't work. Well, that's because you only dosed 50%. So it's our job to make sure we're educating patients to use these rescue therapies appropriately. It may not be a lack of efficacy, but a lack of the provider providing counseling interventions that can support the appropriate and correct utilization of these rescue medications. We'll talk about a case about rectal diazepam versus and maybe transitioning patients to a nasal formulation in terms of efficacy. Obviously, if there's some issues with tolerability, it's really interesting. I have some patients that will say that, they have burning in the nose with nasal midazolam, but not with nasal diazepam, and vice versa. And so, appreciating that patient's clinical presentation and adjusting that rescue therapy accordingly. In general, these rescue medicines are very well tolerated, so I want that to be the take-home message. And then the route of administration, we've already talked about the cost and the lack of access. I want to kind of dive into somewhat complicated topics when we're looking in the adult space, and one of those complicated topics is the issue of pregnancy and whether or not it's safe to administer rescue therapies during pregnancy. Clearly, we do not want to prescribe daily benzodiazepines in women who are pregnant. The outcome is not positive for the newborn. So when you think about the core principles during pregnancy, you want to make sure that patients understand the need to continue taking their seizure medicines. There are some women who haven't been counseled about the importance of taking their anti-seizure medicine. You also want to make sure that if you're looking at changing anti-seizure medicines, that you do that pre-conception, and the recommendation is to have that in place, 3 to 6 months before conception. All women of childbearing age on anti-seizure medicines should take folic acid. That's outside of the scope of this, but just as a reminder. Tonic-clonic seizures can be a huge risk, so really important that you appreciate the potential, so the risk to benefit, right, of treating these convulsive seizures during pregnancy. A convulsive seizure for the patient as well as the unborn child can be life-threatening. So being able to balance that out. And then, stopping anti-seizure medicines during pregnancy should be discouraged. We kind of talked about that. When you look at the guidelines, there's not a whole lot of information on the use of rescue therapies, anti-seizure medicine rescue therapies in pregnancy. There's some anecdotal data, and there's was a recent kind of publication looking at some of this, but we do feel that these medications can be safe when used appropriately. Particularly, when you're not giving them frequently. And also if you have a patient experiencing clusters and a pregnant patient experiencing clusters and that patient has a pattern of clusters that progress to tonic-clonic seizures, you clearly want to be able to intervene. The recommendation is to use the shorter acting rescue therapy, so midazolam, intranasal midazolam. There's also some recommendation for rectal diazepam. I have used PO lorazepam periodically as a part of my seizure action plan for patients who are pregnant, and cautioning obviously overuse. We don't want to overuse these benzodiazepines during pregnancy, but if you're looking at life-threatening seizures, probably important for you to intervene with the rescue plan. Looking at drive, and another thing that those of us in the adult space have sometimes a challenge with in terms of counseling related to driving. This is the American Academy of Neurology, AES, Epilepsy Foundation position statement recommending that driving be paused during medication tapering or discontinuation. They don't necessarily address nasal rescue medications when they talk about the position statements. But clearly if patients are receiving frequent rescue therapies, that means that we need to do a better job with their maintenance medicines, right, to minimize their need for rescue therapies. And then frequent use of rescue therapies, again, signal of poorly controlled seizures. We need to be a little more aggressive with their maintenance treatment intervention. But this is a case, if I'm weaning a patient who is driving off of their anti-seizure medicines, I implement driving restrictions, but I definitely provide a rescue therapy because depending on what literature you look at, 60% of patients may have a recurrence of seizures when you're weaning them. That number is different depending on your research study. But in general, you want to implement a rescue plan and implement benzodiazepines, on the onset of a potential focal aware seizure, for example, that may progress, again, when you're weaning or reducing the anti-seizure medications. You got to be a little careful. Obviously, it's a benzodiazepine, so thinking about sedation when someone is driving. But obviously, if people are having uncontrolled seizures, particularly with a diurnal pattern, so during the day, then they shouldn't be behind a motor vehicle anyway. Nocturnal seizures, a little different story. People shouldn't drive when they're asleep, right? A little difficult. So just ensuring that you're customizing that. But rescue therapies absolutely can be used when you are looking at patients who are driving with epilepsy. Again, if patients, the restrictions depend on the state that you reside in. It's anywhere from 3 months to 18 months. Dr. Servin gave a beautiful talk earlier today talking about the pros and cons of trying to standardize driving restrictions universally. So know your state laws. In the state of Ohio, interestingly, we don't have a designated seizure-free interval, so it's up to the provider. But people used to think it's 6 months, but that, in the state of Ohio, I think there's 5 other states that don't have designated intervals. So be aware of that, and then you want to document that. Again, if you're looking at weaning medicines, initiate that action plan that includes a rescue therapy for patients who are driving. Moving on to seizure action plans. So we know that there are states that mandate that children with epilepsy have to have a seizure action plan in the school setting. We also encourage our adult patients with epilepsy to have seizure action plans. Part of the challenge is that many adults, because of the stigma, they don't want their coworkers to be aware that they have epilepsy. So typically my approach is to tell patients that if you have that one coworker, that you're comfortable with, to notify them of your diagnosis and to make sure they know where your rescue therapy is, when to use it, and how to use it. And so we can implement these action plans in the workplace. Again, there's a huge stigma that in the adult space we have to deal with a little more compared to those of you in the pediatric space when a child is going to school. So that, is a part of the limitation in terms of barriers that we have in the adult space that may not be similar for our pediatric patients. Case number 5, 58-year-old male with poorly controlled generalized epilepsy. He has a history of status, has some caregiver support. You can see the regimen of anti-seizure medicines. He received rescue rectal diazepam, 20 milligrams. He was out in the community, had a convulsive seizure, and received the rectal diazepam. And while it worked really well, there was obviously some stigma associated with receiving a rectal formulation of this rescue therapy in public. Again, it worked very well. There was no recurrence of seizures within a 24-hour time interval. Neurology team initiated a discussion on transitioning that patient from the rectal therapy to nasal diazepam. This is another patient, and this is, I think, interesting. In the adult world, you know, it's kind of funny because I always kind of laugh, like, we don't do math, you know, this milligram per kilogram, like, we don't, just give us a dose. But you have to start thinking about that in the adult space. This is a patient with LGS, failed a variety of different polytherapies, had her on a valproate and then had to reintroduce the valproate. You all know that patients with epilepsy, patients in general, taking valproate can gain up to 30, 50 pounds in a year. We've all seen it. And so in this case, you can see the maintenance medications, and the initial dose of nasal diazepam was 10 milligrams. Over the course of 18 months, the patient had an increase in her weight, went to a neurology visit and mentioned that the clusters that had initially responded to 10 milligrams no longer responded on 2 different occasions, and that increased healthcare utilization. She had to go to the emergency room. And so being able to think about weight changes, even in the adult space, is really important, because part of the reason for rescue therapy failure is because we're not dosing patients appropriately. So making sure that we're incorporating that milligram to kilogram in the adult space, really, really important. And so educating patients on, this is important because now it's not a 10 milligram, but it's 7.5, 7.5. So making sure that you're educating patients appropriately and updating that seizure action plan.
Thank you, Dr. Long. All right, we're entering the home stretch, round number 4. What do you see as the main purpose of a seizure action plan? To guide response during a seizure emergency, educate caregivers and patients, reduce ER visits and hospitalization, improve communication across care teams, or meet school or workplace safety needs. Please vote both in person and online, and we'll see which one of these rises to the top. All right, the main purpose of a seizure action plan: predominantly guide response during a seizure emergency and to reduce ER visits and hospitalization. The audience has spoken pretty definitively here. Let's see what the respondents before the symposium also said. Well, they were more split. Guide response during a seizure emergency, educate caregivers and patients, reduce ER visits was third instead of second, and meet school or workplace safety needs. All right, there's a lot of consistency among the people here attending the symposium. Next question. What do you consider most essential in a well-designed seizure action plan? Clear seizure descriptions, criteria for giving rescue meds, emergency contact info, step-by-step response instructions, or individualized triggers and patterns. As you've noticed in question after question, there may not be, and probably isn't, any one right answer. What do you consider most essential? So the audience in person and online say a step-by-step response instructions. Help the caregiver or whoever's with the patient know what to do. Following by criteria for giving rescue medicines. So know when to do it and how to do it. All right. Let's see what a general audience has said. Again, there's getting to be some consistency among the people attending today, and let's see how it compares to the pre-meeting group. Step-by-step response instructions and criteria for giving rescue medicines were in the top also. So we're seeing some consistency across people who take care of epilepsies. So again, before I turn it over to Dr. Clark, let's review. How do you develop a winning strategy? You recognize what a seizure emergency is with your patients, whether it be clusters, prolonged seizures, or status. You set up a seizure action plan, and you tailor it for the patient. Dr. Long gave some very excellent descriptions of issues with pregnancy or weight gain or driving issues. Dr. Clark talked about how to do it in pediatrics. But now, let's talk specifically about those seizure action plans that we've been alluding to. Are you prepared to develop one? And do you know when to modify one? I'll turn it over to Dr. Clark.
Thank you. I'd just like to tell Dr. Long that it's not a seizure rescue plan, it's a seizure action, got it? Action plan. Well, the question is, are you prepared to develop a seizure action plan, and do you know when to modify one? We've been mentioning seizure action plan for quite a while. You've seen 6 cases, different scenarios, and we've learned over the evening to appreciate it's not a monolith. It's not epilepsy or seizures. It's likely the epilepsies because it's quite unique. So what is a seizure action plan? It's a written plan, detailed guidelines on how to respond when a seizure occurs. But the essential information that's needed with the plan. The first aid, of course, you want to take action and take it quickly. Contacts, when do you up the ante? When do you move on? When do you call someone? Organizing that seizure information, because if you have a seizure in the workplace or in school or at a bus terminal, you want somebody there that can actually take action, especially in the places where you are most, for kids in school, for adults in the workplace and or at home. What is the value of this plan? It provides education and support, as alluded to in the questions. It quite often helps to reduce that anxiety about what to do, not only for the patient, as mentioned before, that could self-administer, but for others, the family members, the teacher, the school nurse, the significant others. And ultimately, the seizure action plan, if tailored correctly, could improve quality of life because you have that control, you can abort the seizures. What should you include? Clearly the seizure characteristics, because all of the 6 cases were quite different. Include within it, especially within the realm of where I sit as a pediatric person, include within it the rescue medication and when to start them, and it's instrumental at school, but you also include the other medications, because quite often these medications have to be given timely and they may prevent the seizure from occurring in the first place. The contact information and instructions are very important, especially in regions that are underserved. You know, I tell colleagues, people travel for 8 hours within the state of Texas to come see me. There are many rural persons that action plan is integral in their management. You have to customize it, as we have said over and over again, both myself, Dr. Long. What's the seizure type? The emergency contact, who most important? What is the type of seizure and information? When and how do I administer that first aid? Treatment information. In that seizure, even with an emergency room in a rural setting, what do I do and how do I do it? This is quite a crowded slide, but it has the salient points. It has the points of what's that first aid for any seizure type. When do I call 911? When is the rescue therapy needed? What do I do not only during the seizure, but after the seizure? What are the special instructions required? Who should receive this plan? I think we have covered this quite well. In a child, anywhere a child spends time, in my mind, And in adults and or teenagers, similarly. Many of the suggestions made by Dr. Long are very applicable to some of my older teenagers, especially when they're transitioning. And then you have general issues, but when you're really ready to jump in and take action, it needs to be bold. So you have the daily educational issues, treatment information, management strategies, but taking action, you have to design it keenly that they can focus on the right thing and do it promptly in a safe manner. And it should be concise, easy to use, and very user-friendly. Because sometimes you don't have the luxury of having a prolonged yellow light. Sometimes you go from A to C very quickly. That standard seizure or seizure cluster occurs. What do you do if that seizure or seizure cluster persists? And when do you call it persisting? So in some individuals, we know that if they have one seizure, it's going to be prolonged. So why wait? In others with a cluster, the family knows if I have more than one cluster, it's just going to keep clustering. Why am I waiting? Hence, having more graphically that acute seizure plan. And you know, we mentioned rectal and limitations, but in my world, some individuals need that rectal diazepam. Some families need that. That's what they can even give best, especially in younger children that may remain aware. They just can't get to that nose. It's just very difficult. And then with that seizure action plan in teenagers, you know, we use it often in kids. Sometimes it's compulsory. But as they transition, what exactly happens? So Dr. Long, what do you guys do?
I wanted to just mention, if you look at the slide, and so clearly it is well established that the pediatric space, you guys are doing a better job than we are in the adult space in terms of seizure action plans. And if you look at this chart here, you can see, or slide, that in at least one cohort, 30% of adult patients, only 30% of adult patients had a seizure action plan, and in another one, 44% of adult patients had rescue therapies. And so I wanted to kind of move forward and talk about an opportunity that we had to disseminate acute seizure action plans in an adult setting. So I was grateful to be on a panel with actually Pat Pinovich and Tracy, where we appraised all of the literature in the epilepsy seizure action plan space, but we also kind of stepped outside of the epilepsy space and looked at an asthma action plan, and were able to create this one page. So one of the barriers in the adult space is time. When we sort of interviewed the healthcare providers who we were interested in assisting with the seizure action plan implementation in the adult space, time was a huge barrier. And so we wanted to simplify the acute seizure action plan, and so we created a one-page seizure action plan that's color coordinated, written on a very appropriate reading level for adults or patients with epilepsy, and we also color coordinated it. So for those folks who had some challenges with readability, the green was standard care, the yellow on the seizure action plan was intervention with rescue therapies, and then the red was when to call emergency services. But one of the things we were able to do in this study, and we published that later in Neurology Clinical Practice in 2024, but patients who were seen in an outpatient adult epilepsy center, we provided them with a seizure action plan and also a written statement on what the seizure action plan is. And they basically, at registration, were able to fill out some of the information on seizure action plans, so demographics and triggers. Some of them were familiar with their semiology, and so they could write information on the semiology. When they went into the clinic visit with their provider, they collaborated with the physician or the advanced practice provider to customize that seizure action plan. This methodology really allowed patients to be in control and to come to that provider and say, I have a seizure action plan, can you help me fill this out? And so in this, when you look at the methodology, once that plan was completed in the clinic setting, patients left with a copy of it and we scanned a copy into their file. We didn't have the electronic seizure action plan in place at that time. We had over 204 participants in this study, and we were able to improve utilization rates in an adult center from 0 to 51%. So we were very excited about this. We also, very importantly, were able to improve the knowledge and comfort scores, so pre and post review of a acute seizure action plan in the clinic setting. We were able to not only have a statistical significance, but obviously some clinical significance as well, where patients and their care partners across the line had an improvement up to anywhere from 83% to 97% on those measures of being able to recognize seizure emergencies, being able to understand what their triggers are, and their comfort in not only recognizing but also managing seizure emergencies. Really, really important. So this was a kind of an initial stage where patients told us their perception of how they felt after receiving a seizure action plan. We now need to move that forward to look at the sustainability of that, and so that's something that we're thinking about. The other thing that was super interesting in this adult cohort is that a couple things. 91% of patients who received the seizure action plan received information about rescue therapies. This is huge when we think about the impact on potentially reducing morbidity and mortality as a result of receiving rescue therapies and customizing action plans. The other really crucial point that patients taught us was that 98% of patients felt that all patients with epilepsy should have a seizure action plan. This was regardless of the seizure burden. So there were folks who were seizure-free in this cohort, and there were folks with intractable epilepsy with a history of status, 98%. Now, this was a disconnect because what we saw with our providers is that utilization improvement 51 was great, wasn't amazing. We needed 100. But there was a disconnect because 49% of patients who were candidates who should have received a seizure action plan did not. And so when we talked about the barriers, one of the perceptions for the providers was that the patient didn't need a seizure action plan. Oh, they're seizure-free, or they don't have frequent seizures. They have maybe one seizure a month. Well, 3 seizures, convulsive seizures in a year increases the risk of SUDEP 15-fold. 3 convulsive seizures in a year increases SUDEP risk 15-fold. So there's a disconnect, and we identified that, and we're sort of moving forward, but appreciate that in this study, 98% of patients felt they needed and deserved a seizure action plan. Healthcare providers didn't feel the same way. So, yeah.
And so, that's fantastic. One limitation I didn't speak about was sometimes the federal agencies, I shouldn't use the terminology, gets in the way, but I'll tell you what happened. We made a more succinct seizure action plan in Texas at the time, but they came back and pushed back, so we ended up breaking even. But it has to be clear and concise. I'm just emphasizing this. Listen to the patient. Personalize that plan. This is key. Make it culturally appropriate, language appropriate. We have to develop one in Spanish in Texas because that's the majority of the population. It's extremely important, and it has to be a step-by-step approach. What do you think?
I agree. I think that using positive reinforcement is important. Reinforcing to the family that this empowers them to feel more comfortable. I often say to them, if you're on a boat in the middle of the lake, if you're driving to Myrtle Beach and you're in the middle of nowhere, you want a seizure action plan, you want a seizure rescue medicine, because you may not always be right around the corner from a hospital. And it empowers them to lead that normal life that they want and the family wants. Oops. There we go. So there are a number of common questions we get asked about rescue medicines and seizure action plans. When and how I should administer it, the rescue medicine, are there any adverse effects or precautions? What do I do after administering the rescue medicine? Can I travel and go to school? How do I update my seizure action plan? With whom do I share it? These are all key questions. And that, how do you handle, pick a couple of them and talk about how you handle them.
So when and how should I administer the seizure action plan? I always engage with the family because they're seeing me for 40 minutes, 30 minutes. The family often knows best. So if they can tell me about that child's seizure, duration, when intervention is required, then we have this banter back and forth. Because again, it's not one entity, right? Are there any adverse effects? I think I covered that. Extremely rare. Never zero in anything we do in neurology, but extremely rare. And can I travel or go to school? Well, I told you guys my answer to that. I think it's extremely important.
And you talked about who you should share it with potentially at work, but how do you update it in your practice?
So it kind of depends on the patient, but typically we review the rescue therapy at each visit. We don't update a seizure action plan necessarily at each visit, but I am curious to know, is that rescue therapy working? Because we talked earlier about ensuring that patients appreciate how to use it correctly, making sure that they know where it is. I've had patients that put the rescue medicine up and they kind of hid it from themselves, so not real helpful. So I always ask them, do you know where it is? Making sure that it's not expired. So we typically will talk about the rescue plan at each visit, but in terms of updating an action plan, it kind of depends on the patient's presentation. Definitely at least annually, but sometimes we do it more frequently depending on their presentation.
And I think you've covered these in what you just said about when we review it once a year and when to review the seizure action plan, especially when there's medication changes or if in rare cases where longer seizures are self-limited. So I just want to wrap up by giving you some of the clinical pearls that we as the faculty feel are clearly take-home messages. Number one, timely intervention in seizure emergencies, whether they be the clusters, whether they be prolonged seizures, whether they be status, is critical. And the best way to be prepared for an emergency is to have a plan. We know that there are seizure rescue therapies that are effective and easy to use and should be a standard part of care for both children and adults who have epilepsy. And our rescue medication choices should be personalized to each patient's unique situation. Every patient with epilepsy should have that discussion and should be offered, and usually they will accept, a seizure action plan and an acute seizure action plan, and that these particular plans empower patients and families and improve their quality of life. But most importantly, they're not fixed in time and space. They can be adapted as needs change. And we hope that using these take-home messages and all the information you've heard today, you've developed or you have an opportunity to enhance your already winning strategy to empower your patients and help them to lead the best life possible. Remember, you can ask questions and answers, and we've gotten a few already, by scanning the QR code with your mobile device and then asking your questions. And we'll go through the questions in just a second. Thank you for participating, but we have one more thing to accomplish, and that's to know whether Dr. Long or Dr. Clark have led the winning team. So, after the last... Oh, the Rescue Rangers have won.
Oh my goodness.
I would humbly...
Well done. See me
I would
afterwards.
humbly suggest that we are all winners.
The check is in the mail.
And I agree with Dr. Clark that we are all winners as we implement this rescue strategy approach and have a winning strategy for helping our patients avoid seizure emergencies. At this time now, we'll dive a little bit into the questions. We have just a few minutes, but there's some outstanding questions that have been asked online. So I'll ask Dr. Clark, what options are available in low resource settings, for instance, developing countries?
That is an amazing question, and it varies. So in some instances, and colleagues of mine in Kenya and sometimes in the Caribbean also, which I have some colleagues here, have actually used the IV preparations of diazepam, and I've pulled it up and given it that way rectally. There are a few countries where you can actually get the rectal diazepam or something intranasal or sublingual lorazepam, but it's far and in between, and there needs to be sustainability. And one other question I would answer, but posed by myself, I think, as stated here, pending where in the country, what country it is, or with what region, what sensitivities, you have to tailor it to that region.
Thank you. Dr. Long, what about patients who have dementia, who also have acute repetitive seizures, and plus minus they occur during parts of their life where they may not be exactly with it? How do you handle that with their families?
Sure. So typically those patients don't reside alone. And so we educate their care partners to initiate rescue therapies when appropriate, kind of similar to what we would do with any of our other patients who need a rescue plan in place and a care partner to initiate that. So very important that we incorporate patient, not just patient education, but care partner, family member, nursing home education as well. So we customize that and incorporate the care partners to facilitate that.
So there's a question I'm about to ask where the answer is always going to be, it depends, but I'm not going to let our faculty get away with this answer. So, do we really need to recommend that you wait X number of minutes when you see a generalized seizure?
It depends. No. But truthfully, that's a huge debate. And in my mindset, if a family knows that seizures are prolonged, or if they have infrequent seizures, but they have a fear factor and anxiety, it's extremely important to address it. So in those instances, I don't dissuade families from giving it earlier. I know it's not a perfect answer, but that's the answer I usually come up with.
Dr.
I
Long?
actually love that question because we've already established that 5 minutes constitutes a life-threatening seizure. The patient is in status, particularly convulsive status, in 5 minutes. And so I love that question because it helps us to reiterate the importance of customizing care. We know that most of the convulsive seizures last less than 2 minutes, sometimes even less than that. And so for me, it's all about that pattern. What is that patient's clinical presentation? I would suggest that we don't need to wait 5 minutes for most patients who are undergoing prolonged seizures. Again, we want to minimize the seizure burden, and the sooner we intervene, the better. So I really love that question because it just reiterates the importance of customizing care, sooner intervention rather than later.
And just to be fair, I talk to my families, just to be fair that I'll answer the question too. I talk to my families about go get the medicine at the start of the seizure, along with making sure there's someone with the patient, because by the time somebody actually goes and gets it, it's usually 2 or 3 minutes. By the time they find it and they get it, it's not always right there, and the seizure has slowed down or stopped, actually. And therefore, they have it, they're ready, but they don't have to use it. But they feel like they've done the right thing, and I feel like they've done the right thing too. But again, it depends.
And the issue remains that in the hospital, we very seldom wait 5 minutes.
Right.
But we're asking families to sit down and look at their child seizing for 5 minutes. And it's an extremely long time if you ever time it.
Really good point.
I actually sit there in the clinic at times and I say, let's look at the clock, and I will tell you how long 5 minutes is, because we sit there in silence and we stare and the parents go, I can't wait that long.
Exactly.
Oh, wow.
I can't wait 5 minutes.
Exactly.
They usually around the 2 to 3 minute mark they say that. All right, do we need to wait if the patient and the family know that the patient who's having a complex partial seizure always goes to a generalized tonic-clonic? How do you approach that?
No, we do not need to wait. We want to minimize the progression of the seizure. So that's a great case because what the participant said was always. So that tells me that person has established a pattern and has kind of questioned their patient appropriately. They said always. And so I would suggest that no, you want to intervene sooner rather than later, and being able to appreciate that clinical presentation helps you implement that customized plan so you can initiate intervention sooner rather than later.
Dr. Clark, are we seeing rectal diazepam still being used as rescue medication in pediatrics? And if so, where?
In some instances, it's still being used. I alluded to one earlier. Pending the seizure type, it's very difficult sometimes to get that intranasal with a patient, and they may use it rectally. But because of the psychosocial issues, my use have significantly declined over time. I don't think it's appropriate if someone is having seizures frequently during the day and you can get an intranasal medication for them to risk that social isolation and stigma. So I quite often transition them early.
And what about the two ends of the age spectrum? Very, very young and very, very old. And I don't mean to be pointing to you guys that way, sorry.
Wise is the new old, so very wise.
Yes, very wise, very young and very wise. So how about in the very senior patients?
I very rarely use rectal diazepam. I do have some patients, about maybe 30% of my patients are static encephalopathic, but even in the majority of those folks, we're using nasal. I do have some patients, as I mentioned earlier, who they prefer to use the rectal at home. And so again, just customizing that, allowing patients to appreciate what their preferences are can be helpful, but the majority for adults, we tend to use nasal.
And for the very young?
And for ease of use, even in the very young, quite often we transition, but not always.
So I want to thank Dr. Long and Dr. Clark for participating with me today to hopefully share with you what we believe is a winning strategy to help our patients avoid their seizure emergencies, empower them to lead the best life possible, and we hope that you have found this information informative and enjoyable. Thank you all very much.
Thank you.